So for those of you who don't know me already, my name is Gemma Nunn. I am the Clinical Training Manager covering Europe here at Leo Cancer Care. Previous to that, I'm also a therapeutic radiographer. I spent almost 10 years in the NHS treating patients prior to joining Leo. So that's a bit about me. And obviously I'm joined by Sophie Bouvier, the author of this great paper. I'm very, very excited to be listening to this today and sharing it with you. So Sophie, if I can hand over to you to just introduce yourself and if you'd like to carry on with your presentation.
Thank you, Gemma. Good afternoon, everybody. Good morning. Thank you for giving the opportunity to share my work. My name is Sophie Bouvier. I have been working as a radiation therapist for 15 years at Léon Center in Lyon, in France. And the objective of this webinar is to present you my findings on the upright positioning for patients treated with radiotherapy for pelvic cancer. First, as you know, radiation therapy treatments are performed with patients in supine position. Our patients were set up with immobilization devices designed for this position, and the treatment is delivered with a gantry rotating around them. However, some publications showed the upright position may be beneficial for the patient and their treatments. Indeed, it has been shown that respiratory motion in craniocaudal direction is reduced in upright position compared to the supine position. Moreover, the lung volume is significantly higher in standing and sitting positions than in supine position. So this data suggests that for lung irradiation, the upright position may be associated with a lower mean lung dose. Now, regarding pelvic tumors, it has been demonstrated that first, the bladder is more elongated in the anteroposterior direction in upright position compared to the supine position. In addition, the distance between the sacrum and the bladder is reduced in upright position compared to supine position. And finally, the changes in bladder filling don't modify the prostate position significantly. If we summarize, the bladder may avoid the small bowel to fall within the pelvic area in upright position, and the constraints for the patient to fill the bladder in the same way may be less important. Macarol et al., with testing upright position with head and neck cancer patients, showed that patients were more comfortable in upright position at the back level compared to the supine position. In this context, in March 2021, the EV positioning system was installed in Lyon by Leo Cancer Care team, and a research program was developed. This program includes 3 main steps. First, the development of immobilization devices and methods for patient positioning. Second, the assessment of patient positioning and immobilization accuracy. And finally, assessment of organs position and motion. In this first study, we had 3 objectives. First, we evaluated the upright positioning and immobilization accuracy based on the inter- and intrafraction deviations. Second, we assessed the setup duration with duration of the first positioning, repositioning, and uninstallation step. Third, we compared the patient comfort in upright and in supine position. This study was carried out for adult patients with a curative pelvic radiotherapy treated on an Elekta linear accelerator or tomotherapy unit. Regarding the upright positioning system, here you have a picture of the device with in one in the backrest. the sit-down in 2, the shin rest in 3, the heel stop in 4, and finally in 5, the one prototype of arm rest. The whole device is on a platform which can rotate with helical movement. In addition of the positioning system, there is an optical guidance and tracking system developed by Leo Kanseker with 2 20-megapixel high-resolution optical cameras, which are set at 90 degrees apart from each other. A software completes the device and allows to compare the live image in green and the reference image in pink and quantify the deviations between both images. Regarding the patient workflow during this study, the patients were treated in supine position with a head cushion, knee cushion, and a minimum of 3 tattoos. The patients included at 3 additional appointments. At the first appointment, we set up the patient on the upright positioning system. We recorded the position of the different parts of the device and acquired the optical reference images. During the second and the third appointments, patients were repositioned on the upright positioning system, and a treatment session was simulated with several helical movements during 20 minutes. Now, look at the process to set up a patient on the upright positioning system. First, the backrest was positioned with an angulation at 5 degrees backward and the sit-down at 50 degrees to have a position close to the standing position. A vacuum cushion was set with more beads on both sides and at the lumbar curve. Then the patient was invited to get in the device and stay in standing position with legs against the vacuum cushion. The seat height was adjusted according to the patient's legs length, and we moved the shin rest closer to the patient's legs. The patient could sit up on the vacuum cushion, and the shin rest and heel stop were adjusted according to the patient. Finally, head cushions, arm support, and belt were positioned, and vacuum cushion was modeled. The data collection of this study included patient characteristics like age, patient height, patient weight, etc., but also the patient setup characteristics with seat height, shin rest position, and heel stop position. First positioning, repositioning, and installation durations were collected. Interfraction and intrafraction shifts were also collected, and the patient satisfaction regarding their comfort in upright and in supine position was gathered on specific questionnaire. Now look at the results. Between October 2021 and June 2022, 8 men and 8 women were set up. The age range of the patients was between 35 and 81 years. 3 patients had postoperative radiotherapy, 7 had chemoradiotherapy, and 7 had exclusive radiotherapy. Regarding surgical history, in addition of the cancer disease, 3 patients have had knee surgery, including 1 patient with a knee prosthesis. No large weight changes were observed between the first positioning in upright position and the last appointment. If we look at the patient setup time, in average, 40.4 minutes was needed to set up a patient at the first time with 1 radiation therapist and 5 minutes with 2 RTTs. The repositioning step took in average 4.9 minutes with one RTT and 2.9 minutes with two RTTs. Finally, 2.5 minutes were needed to get out the device, for the patient to get out the device with one RTT, and 0.6 minutes with two RTTs. All these results were statistically different with smallest duration with two RTTs. Based on 40 patients with two repositioning setups and 2 patients with one repositioning setup, the interfraction shifts mean were minus 0.5 millimeter in right-left direction, minus 0.4 millimeter in anteroposterior direction, and minus 0.9 millimeter in craniocaudal direction. For one patient at the second repositioning, large shifts were observed in right, left, and craniocaudal direction. Minimum of 90% of the value collected were inferior or equal to 3 millimeter, as we can see on the diagram with the purple bars. Regarding intrafraction accuracy, after 20 minutes on the upright positioning system, the shifts mean were 0.2 and 0 millimeter in right, left, anteroposterior and craniocaudal direction, respectively. More than 80% of the shifts collected during the treatment simulated were smaller than 1 millimeter. On the 15 patients who filled the questionnaire, 13 patients were at least comfortable in upright position and 11 in supine position, with one patient who was in pain in supine position. These results concern the global comfort. Now, if we look at the different parts of the body, at the arms and shoulder level, 12 patients were at least comfortable in upright position and 9 patients in supine position, with 2 patients who were in pain in supine position. 13 patients were comfortable or very comfortable at the neck and back level in upright position, and 11 in supine position, with 2 who were in pain in supine position. 12 and 13 patients were at least comfortable in upright and in supine position, respectively, at the head level and also at the abdominal level. For the hip and legs comfort, 13 patients were comfortable or very comfortable in upright position and supine position. It was at least easy to breathe for all patients in upright position and for 13 patients in upright position, in supine position, sorry. 13 and 10 patients found easy or very easy to set up in upright position and in supine position, respectively. It was easy or very easy to get out the position for 14 patients in upright position and for 9 patients in supine position. Finally, 13 and 10 patients felt stable in upright position and in supine position, respectively. So, what we can say about these results? The first positioning and the repositioning time were reasonable with 1 radiation therapist and shorter with 2 radiation therapists. The first positioning, including the definition of the patient and chair position, corresponds to the actions which are typically done in the CT scan room. In upright position, a vacuum cushion was molded for all patients, contributing the patient comfort and somehow repositioning and stability. This step significantly decreased with the presence of 2 RTTs, which is completely unstable. Confidence and expertise can also contribute to the time saving. To our knowledge, there are no data in the literature regarding the first positioning duration in supine position for pelvic treatment, but Mannerberg et al. Reported a mean repositioning time in supine position for prostate treatment of 2 minutes, 50 seconds, which is consistent with our results. In upright position, the interfraction shifts mean were below 1 millimeter, allowing an accurate repositioning. And these results were obtained without patient alignment with laser, without skin marks, and without RTT to move the patient. Because SGRT is now widely used to quantify setup, reproducibility, and immobilization in radiotherapy, we can find in the literature several studies showing a good correlation between SGRT or video images with a PAD based on the body registration in supine position. Putting together this data and our results, it looks like upright positioning definitely warrants further considerations. The intrafraction motion was within the 1 millimeter for more than 90% of the patient images in a 20 minutes time frame. So the patient stability was excellent in this position. If we consider a treatment time only for the beam, for the mat irradiation in supine position is within 3 minutes, the upright position should allow a safe treatment delivery. Regarding patient satisfaction, the results were promising, with patients at least as comfortable and as satisfied in the upright position, and sometimes even better than in supine position. Some improvements are possible, in particular in the design of the head cushion and the belt. Our study has few limitations. First, the sample included only 16 patients with a maximum of 3 setups. Secondly, the inter and intrafraction assessments were based on the skin match with optical images. This doesn't guarantee that internal organs and tumors will also be positioned and repositioned adequately. Thirdly, we only did in patients with pelvic tumors. The results of this first study on pelvic cancer patients set up in upright position on the Leo cancer care chair is promising and open a potential new direction for radiotherapy treatment. Considering the limitations of this study, patient positioning assessments with head and neck cancer patients and also thoracic cancer patients are ongoing. The next steps of this research includes a work on patient positioning and mobilization devices development for all the treatment localization, but also a clinical trial to compare the organ position and their motions, and thus the dose distribution between upright and supine position. Thank you for your attention, and I would like to thank the staff of Radiotherapy Department of Léon Bérard Center, Professor Vincent Grégoire, and Radiation Therapies team, as well as the Leo Cancer Care team.
Thank you very much, Sophie. And I'd like to echo that back at you. Thank you very, very much to you and everyone that contributes at Centre Léon Bavard. It's an absolute pleasure to be working with you. And I think you've summarized it up beautifully there. I think this is a great start to this kind of research and looking at patient positioning in the upright position. So thank you very, very much. And before I forget, I'd just like to thank, there's a couple of people on this call from the Leo team as well that are doing technical support and ready to jump in with questions. So thank you to them as well. I just have a question, Sophie, just to kick things off, and then I can see there's one come through. My question to you is, in your personal experience, what benefits do you see as a therapist from utilizing upright patient positioning?
I think if we look at first the upright positioning system, we think that there are a lot of parts of the device to adjust it for one patient. So it might be a little hard, but no, definitely it's not at all. We have just to follow step by step a very easy process to set up a patient. And finally, the positioning duration show that is not that not takes a lot of time, and we are not a lot of difficulties to set up a patient. And the repositioning step is very, very easy.
Thank you, that's brilliant. And as we all know, particularly one of the key things in radiotherapy is reproducibility and stability. And this really does encourage us to, to do further research into this, but also sort of into the patient experience and comfort elements as well. And this is an area of radiotherapy research which is quite lacking. And also there's been a study that's recently just been published by Simon Goldsworthy et al., which looked at patient comfort and experiences along the radiotherapy pathway. And I wanted to mention it because I feel like it really lends hand in hand to what we're seeing here, Sophie, and the benefits. They did interviews with radiographers and patients, and there were 4 main themes here, and 2 that came up across both therapists and with patients was emotional health, but also positioning and immobilization experiences, which is kind of what you've asked patients in your study to do here with different parts of their body. And it's very key. It's filling a gap in research, but also what we're doing here at Leo Cancer Care with, we can't be the more human way if we don't consider patient experience and their comfort in this. So I think this is really, really fantastic. And thank you again. So just going back to, there's a couple of questions coming through now. So the first one here is, if it takes 2.5 minutes to get out of the device, what is the plan in case of worst case, like a cardiac arrest? Can it support their weight to prevent further injury from fall? Do you want me to take that one, Sophie?
No, I can't.
So from our perspective, we have 2 mechanisms at the moment. So we have a Z platform descend mechanism, which is to be used in an emergency scenario. This descends the platform, the rotational platform, at height. So the patient positioning device comes down to floor level, and then we can release the shin and the heel mechanisms to evacuate the patient quickly in such a scenario. But also we use currently the abdominal belt that we can use around the patient so that they kind of feel a bit more supported, and that would also sort of hold them in place a little bit should they faint or something like that. So there's kind of a 2-pronged approach there currently. So that's that one. And I've just seen another one here. It says, do you image match, and what type of beam arrangement was used to treat?
So in this study, we didn't treat the patient in upright position. We use only optical images in frontal view and lateral view to check the patient positioning, the skin match, and for the 10 first patients, I was alone to check this position, but for the 6 last patients, we were 2 radiation therapists to check the patient positioning.
Brilliant, thank you. Okay, thank you. Next one then, Sophie. I noted that you noted that some of the patients had knee problems. Do you know how these patients specifically responded to your questions on comfort of the upright position setup? Were they okay?
We didn't find any correlation between comfort and knee surgery, but I paid attention about this point. But in fact, the shin rest is a part that we use to support all the leg, not only the knee, and maybe not the knee, but all the leg, along the legs, so there are no discomfort on this part of the body. Some patients describe a small discomfort, but it's mainly due to the shape of the shin rest that maybe currently it's not completely adjustable for all patient morphology, but future version of upright positioning system can be offered this possibility.
Brilliant, thank you, Sophie. And there's just one more cropped up here. It says, I'd be interested to know how the intra and interfraction motion was measured, x-rays with bony structural references. I think this is sort of similar to what we've answered before. So we used an optical guidance system with skin tracking currently. And as you suggested, that's something in the future development with the introduction of the upright CT scanner that we will be developing with studies in the future to gain more insight into that information.
And if we can add something, we check the skin position on the belly part, on the pelvic part, on the tight part of the patient.
Thank you. And there's another one here. Do head and neck patients experience vertigo with 6th couch corrections, i.e. if shifted off axis by 2 degrees forward?
So we have just started the head and neck cancer patient assessment in upright position. So first I just set up for the first time my patient and both and 2 volunteers. So we use a backrest with a position of 5 degrees backwards, because based on previous tests, we can see, we were able to see that it was the most preferred position for the majority of people. Now, if it's necessary to change because the patient is not in comfortable position, we can change to use 0 degree or 10 degree backward. Now the CT scan as studied will give us more information about the consequence of the angulation, the inclination of the backrest, obviously.
Brilliant. Thank you very much for that, Sophie. Also with reference to patient experiences, we have a lot of fun here testing ourselves and getting other people involved. And what we also find is that the movements are so smooth that if you shut your eyes, particularly when you're going sort of up and down, you don't even notice, you're not aware that you're being moved, particularly up and down. It does 1 RPM a minute, so which we've also tried to replicate here. It's on our social media posts with some of the guys in the office here with an office chair. So please take a look. It's all been done with the patients very much in mind and no harsh movements, because once you've done your image matching and things and you're moving to your treatment position, you also need to know that that sort of jerking movements isn't going to change into fractional motion as well. So it's really important, and it's something we've worked really hard on. Lovely. There's some more coming through now. So the next one is how well is the reproducibility for obese patients?
Sorry, can you repeat, Gemma?
So what is the reproducibility like, or in your experiences with more obese patients?
More obese patients, sorry. So the large, especially for one patient, we had large shifts, but it was not the patient larger, and we had one obese patient in this study, but we didn't find any problem to reposition. And more specifically, I was completely surprised on the repositioning of the belly of this patient. And when I saw the NVCT for the treatment, and when I see my optical images, I was completely surprised. And I would like to see CBCT in upright position to confirm that internal organs will be in the right position. Yeah.
Brilliant. Thank you for that, Sophie. And another question, what about patients with full bladder protocol? Are they comfortable for 25 minutes? I think I would refer to Nick's paper here, one of our clinical advisors. He did a paper recently that he's published where they took some MRI scans of pelvises for prostate patients, prostate participants, in the supine and an upright position, and they compared the placement of the anatomy and the significance of having sort of the bladder positioning, really. And the initial findings of that seem to suggest that potentially an absolute full bladder, like we're used to doing at the moment, may not necessarily need to be as full as what we use currently because of the positional change in the anatomy. But again, it's very promising. It was a very small study. It was only about 3 to 5 participants. And again, it just seemed that the full bladder protocol wouldn't be so critical. I think in my own personal experience, I would go more with a sort of comfortably full, or even looking at reducing that volume based on that result of that study in the future, which I'm hoping would make patients more comfortable. Lovely. There's another one here. So it says, regarding the position shifts that were reported between appointments using the OGS system, you showed the mean and standard deviation. Can you comment on how you measured this? It would be more useful to see the distribution of the shifts for all patients rather than the average. And then in brackets, I saw a 0.0 average, so I must assume you measure positive and negative shifts. Are you able to comment on that, Sophie, how you measured your averages for that?
So on the software of the optical guidance and tracking system, I was able to, I can measure the live position, the current position, and the reference position of the patient. And the measure was in millimeter. Yeah. Mm-hmm.
Okay, brilliant. Okay, and that brings us to a close there. I think that's a good natural stop to come to there. So once again, I just want to thank everybody for giving up their time today to come and join us to hear about this exciting research evidence. And again, thank you to Sophie and everybody at Centre Léon Bavard and the people working in the background here at Leo Cancer Care. It's been an absolute pleasure, and thank you very much for your time.